Ladies and gentlemen, I'll go ahead and call our meeting to order. You don't have one of those? Jesse, have you got another folder? I think we're missing one right here. Good. Well, first of all, welcome and thank you all for coming. Everybody looks pretty bright-eyed this morning. We had kind of a late evening last evening, and some of us are a little more tired than others, but thank you all for coming and thank you for your interest. We thought since we had a little time here that it would be a good idea to ask the department to come in and give us a briefing on the progress with Navigant and what's going on, and I know there's a lot of interest in that, certainly on our committee's part as well as general interest out there. And I want to just, before I do that, make a couple of just remarks in general, and I want to say thank you. I want to say thank you to the governor and his leadership that he has put forth with his health care initiative. And I think from talking with most of you, the places that we were able to start with the budget, we were in much better places this year than we have been in some time in the past. And a lot of that was due to his leadership. And then certainly on the House side, I know that our group was committed to try to work to do the very best we could with the dollars that were available. And I also want to publicly thank the department. I've said this privately to the commissioner and to others, but I want to say it publicly too. We've gotten great cooperation out of the department. Anytime we had issues that we needed to discuss or talk about, they were always willing to come to the table and help. And when we had to work out some solutions to some problems and situations, they were always forthcoming, and just a real good attitude over there about working with us and all of us working together to get to the same goal when we got through. So I want to just say that. And also our committee's been very involved through the process, and as we work through the budget, we got most of those things that we were able to address, a lot of the issues that you all brought to us. And that's not to say that we were able to do everything, but I think that we did many of the things that you all had shared with us that were important to you. So we thank you for your input in that too. Now, what we're going to do today, Deputy Commissioner Blake Fullenwider is going to make a presentation to us, and I'd like to let him go through his presentation, and then when he finishes, we'll have time for the committee for some questions and discussion that you'd like to have. And so we'll just do that, but let's wait until he finishes his presentation, and then we'll go through the questions and answers. So with that being said, Blake, we'll turn it over to you. Thank you.
Thank you, Mr. Chairman, members of the committee, ladies and gentlemen. Thank you for the opportunity to be with you this morning to provide an update on the Department of Community Health's Medicaid Redesign Initiative for our Medicaid and CHIP programs. This is a huge undertaking that began about a year or so ago and will continue for quite some time into the future as we look at how we deliver care in our Medicaid and CHIP programs and identify ways that we can improve the way that we handle that. Just a little bit about the Medicaid program. We cover approximately 1.7 million people under today's program, and that's either in Georgia Families, which is our managed care program, or for those age, blind, and disabled individuals who are served under a fee-for-service model. Under today's system, approximately 1.2 million individuals are in the Georgia Families program. Medicaid pays for approximately 59% of all births in the state, and that represents about $31.6 million in paid claims per day, and that represents about 176,000 claims transactions processed in the program each day. So with that, to start a little bit about the redesign initiative, Jesse, if you could turn to slide 3. Members, you should have a hard copy slide deck. We are on slide 3, so we'll see if we can get this ironed out. Navigant Consulting was contracted by the department last summer through an RFP to provide assistance through the initial analysis all the way through the implementation and up to go live of a Medicaid redesign initiative. They're a global consulting firm with a wealth of experience in a broad host of sectors, but healthcare in particular. They've worked with virtually every Medicaid program throughout the nation, and so they're bringing a wealth of knowledge and experience in these programs to the department and assisting us with our review. Again, they will work with us. They have been working with us since the outset and will continue to work with us through final implementation. Up to this point, we've received a strategy report that I will mention in just a moment, but the Navigant team is also coordinating 3 task forces that are working as we speak. Those are focused on issues that providers face, those issues around the age, blind, and disabled population, and those also particular to children and families. To the next slide is a little bit about our timeline. This process started, the analysis started in August 2011, and we anticipate completion in the early part of 2014. We've completed the assessment phase and have received the design strategy report, also commonly referred to as the Navigant report, in January of this year. Since that time, which takes us into the recommendation phase, we've been digesting that report, vetting it with stakeholders, with members of the legislature, with the governor's office, and many others to begin to develop our assessment and steps going forward. We anticipate completing that process according to this timeline in April, which would move us into a procurement phase where requirements would be set forth and we would move to issue an RFP or RFPs in the middle part of July. We would use the remainder of this year to conduct procurement activities with the intention of being prepared to award contracts in early 2013. We would utilize the year of 2013 for any implementation and ramp-up activities that are necessary for an anticipated go-live January 1st of 2014. The strategy report that I mentioned is composed of 3 distinct sections. The first is a national environmental scan where the consultants took a look at all 50 states and their Medicaid programs and tried to identify some unique things that these states are pursuing, whether they be demonstration projects or waiver programs, things like that, or just in their core Medicaid programs. They also focused on 12 states in particular that were of particular interest. They also conducted a Georgia-specific environmental scan, which took a look at how we've been doing, how we've been running the program, the Georgia Families Program, as well as our ABD programs to date, and provided their analysis. And finally, the report concludes with options and recommendations for steps going forward. These recommendations are based on goals and strategies that the department outlined to the consultants at the outset of their review, and I'll touch on those in just a moment. The goals, we identified 3 key goals and 6 strategic requirements to get us there. The first is encouraging appropriate utilization. This is both over and underutilization to find the right level of service delivery. We also must achieve long-term savings that are sustainable, and we also must improve the quality of healthcare outcomes that are provided to the members in the program. So how do we get there? We identified 6 strategic requirements to help us reach those goals. The first is gaining administrative efficiency to become a more attractive payer for providers. I think we've all heard of administrative challenges that providers often face when dealing with our Medicaid programs. It is part of this initiative and a priority for the department to identify areas where administrative burdens can be eliminated or streamlined and the provider experience can be enhanced in providing services through our Medicaid program. We also must ensure that we have an adequate network so patients are able to access care. This is a particular challenge in our state because of both our urban and rural nature. This is also particularly important for specialty care in rural parts of the state. That is a challenge, but it's also a priority for the department to ensure that our members have appropriate access to care. And we also must maintain a program that is operationally feasible from both an administrative and a financial perspective. That takes into account the resources we have at the department to administer a program of this magnitude and the constraints that we have to deal with in that light. Continuing with the strategic requirements, we must align reimbursement with quality outcomes and not the quantity of services provided. And this really gets at driving improved quality and patient care in the system, and not simply paying claims based on the number of services that are provided, but really putting a focus on delivering high-quality care. We also must encourage personal responsibility and engagement in prevention and wellness activities, things such as smoking cessation programs, chronic disease management, medication therapy management, and others that are cost drivers in our system. If we can identify these potential areas and get the members engaged on the front end, we have the potential for long-term achievable savings in the system. And finally, scalability is essential. We are not certain, as the Supreme Court takes up the Affordable Care Act this week, we are still waiting to determine whether or not we need to anticipate or expect to have an expansion population of 650,000 or more coming into the program. So we need to be sure that we've got a program that can be ratcheted up if necessary, or maintained at a relatively current level, depending on the outcome of a lot of unknown variables with that case. The next slide is what we call the first bubble chart. And to preface a little bit about what you see here, on the left side are the goals and strategies. Along the top are 9 distinct options, and these really vary depending on the extent to which care is managed or how that care is managed. And it goes from a traditional fee-for-service system, which is relatively little or no managed care, all the way to a fully capitated at-risk managed care program, and even one step beyond by taking a look at how a defined contribution arrangement might work for this population. The color coding on this chart indicates whether or not each particular option would help us achieve, would not help us achieve, or would be somewhat indifferent to reaching our goals and strategies. Green identify those areas which would be more successful in helping us achieve our goals and strategies, while conversely the reds would be those that would not, or have the potential to take us in the opposite direction than we identified. To run through these very quickly, the first option is maintaining our current delivery system. This would maintain the Georgia Families Program for our low-income Medicaid population while maintaining our aged, blind, and disabled populations in a traditional fee-for-service model. Option 2 would transition Georgia Families into a fee-for-service model, whereby the Department of Community Health would administer the program and all payments would be made to providers on a fee-for-service basis with little or no managed care. Option 3 is a patient-centered medical home model. This is a model whereby provider groups would enroll into the Medicaid program as a patient-centered medical home, and providers would be paid on a fee-for-service basis with some shared savings requirements with the Department of Community Health. Option 4 is an enhanced primary care case management model. This would assume all populations would be served in an enhanced primary care case management model, and the state would pay providers directly. There would be an agreement with a vendor running an EPCCM model to reach some shared savings agreements in that type of arrangement. Option 5 is an accountable care organization model. This is one that has gained quite a bit of national attention, is somewhat yet undefined, but it would envision a large provider group or a hospital system with an extensive array of services that they're able to offer to contract with the department on an at-risk basis and provide services for a membership for that amount. They would be responsible for any costs that would exceed what the capitated payment from the department would be. So the challenges with that would be identifying provider groups that have the financial backing and stability to be able to take on that risk. Option 6 is what we call Georgia Families Plus, and in this model it simply envisions managed care for all populations and all services. So this would include bringing the aged, blind, and disabled population into a managed care program, and would also wrap any carved-out services, which would be the non-emergency transportation services in Georgia, would also be included in that model. Option 7 is a health savings account with a high deductible plan. I'm sure you're all familiar with health savings accounts. This would envision a model whereby you provide an HSA to a Medicaid member and they participate in the program that way. There are some challenges with this model, however, because Medicaid is a entitlement program. Some states have attempted this, and they've found that the built-in cost containment mechanisms through an HSA don't really have a real effect, because once a member actually utilizes all of their HSA funds, the state is still responsible for providing the services, and so they pay after that on a fee-for-service basis. Option 8 is a commercial-style managed care program. This model would envision managed care for all populations and services and would include enforceable copays and other commercial-style incentives, if you will, levers that are currently prohibited under the federal law in the Medicaid program without a waiver. This would require the department to seek a waiver for those services, and that would be a challenge that we would need to address. The state of California recently applied for a Section 1115 waiver to that effect to apply enforceable copays, and CMS did decline that request. So that's one thing that we will have to keep in mind. Option 9 is finally the free market purchasing or a defined contribution arrangement. And under this model, the Navigant team identified a managed care program for a portion of the population, and then considering a defined contribution arrangement for the expansion population that will be coming into the program in 2014, notwithstanding any other adverse action to the law. So that's the menu of options really across the board that the Navigant team assessed. Moving to the next slide, they took elements of those 9 options and pulled out the areas that they identified that would be most successful in achieving our goals and strategies, and combined them to form 4 hybrid models. The first is the Georgia Families Plus program, and this again is managed care for all populations and all services. Option 2 builds upon option 1 by including the enforceable copays or other incentives, the commercial style levers. Option 3 builds on the previous 2 by requiring that a managed care entity contract with patient-centered medical homes and ACOs within their networks. And finally, option 4 is a combination of Georgia Families Plus and a defined contribution arrangement for the expansion population. The goal of this initiative and the underlying premise for this redesign is to drive value-based purchasing, and that is it's a broad concept and can be defined in many different ways, but simply put is being better able to identify what we as a department want to purchase as the state's largest healthcare purchasing agency in the state, defining what it is we want to purchase, assessing what we're getting. That includes making sure that we are enforcing our contracts with our vendors, being sure that we're able to verify that what we've agreed would be provided is being provided to the members, and then finally using those lessons learned in cycles going forward. So this really is central to the entire effort. We want to drive the notion of value-based purchasing, the principles of value-based purchasing in our Medicaid program forward, and we're in a unique opportunity at this juncture to do that. Again, the strategy report was released in late January. It's been out for several weeks. We continue to work with our task forces, and we also continue to engage with stakeholders on both in a group and a one-on-one basis to hear feedback, to receive proposals, etc. We've really gotten a great deal of interest and a great response from those involved. That anyone that the Medicaid program touches has been great in providing their feedback to the department. We look forward to taking that into our steps going forward. And with that, Mr. Chairman, that concludes my prepared remarks. I'd be happy to answer any questions you may have.
Okay, thank you, Blake. I'm sure we might have a few. Any member of the committee? Well, let me ask you this, but if you would, you touched on this about, and of course, I guess none of us really know what's going to happen in Washington right now, or exactly how that's all going to play out. But if this goes forward like some think that it may, you're talking about the possibility of picking up another 650,000 people, right?
Yes, sir.
What kind of cost do you envision this would be?
We have the department is currently working on updating our projections for the Medicaid expansion population, both in terms of number and as well as in cost. I can provide you with numbers from an August 2010 run that would indicate that we would expect to add to Georgia's rolls approximately 656,000 newly eligible members at a state cost from 2014 to 2020 of $2.4 billion, combined with $23.1 billion in federal funds, for a total of state and federal expenditure of $25.5 billion.
Pretty expensive tab.
Yes, sir.
Good. Representative Sims.
Mr. Chairman, I'm just wondering about your timeline. Do you feel like that's a confident timeline, or with all this other coming along, how far out maybe are we looking?
Well, I think that's an excellent point. The priority for the department is to do this right. And we've heard from a number of stakeholders who have expressed concern that our timeline is too aggressive. As we proceed through this process, and if our timeline does need to be adjusted, we will adjust that. The important point is to be sure that we have the input that we need and the information that we need to be able to make sound decisions going forward.
Thank you.
President Gordon.
I think my questions were about the timeline too. You showed us what I think is a pretty optimistic timetable, which suggests that you're pretty ready to go ahead with the RFPs. I mean, is that accurate?
No, Representative Gardner, I don't believe so at this point. We are still very much in the analysis phase. Mm-hmm. Again, I think this timeline is a bit aggressive. It may need to be adjusted, but we will not move forward with issuance of RFPs until our requirements and our decisions have been fully vetted.
I've got a lot of questions. I'll ask a couple more if I can. I'm interested in the way a couple things is this chart with the nice colors. I mean, who assigned the green, yellow, and red dots, and what was kind of the basis for the decision making about what values you put on each of those, and where's the backup kind of?
Our Navigant consultant team assigned the values. This is based off of a Kepner-Trigo decision-making tool. I'm not particularly familiar with that format, but it is a strategic business decision-making tool that was utilized. The backing behind the I guess the scoring behind these metrics is Navigant's research and their experience both within Georgia and across the country. It's really based on a number of things, data-driven and also just empirical evidence that they've observed as they've worked throughout the nation on these programs.
And there is backup? Is it that's available for us to sort of look at about how they made these determinations?
Yes, ma'am. Many of the decisions are supported in the appendix section of the full Navigant report. They do have a number of data sources and citations that drive these decisions.
Okay. And then what you've done, which I hadn't seen before, is create 3 options or 4 options by combining some. Am I in the right? Yeah. So you've put some of the various options together, like 1, 2, 3, and 4 is in one option. Is that right?
I'm sorry, I don't follow.
I'm not sure that I'm a little confused about
the 4 options that are presented are the Georgia-specific hybrid options. These are those that combine the elements that were identified to be the best. I want to underline, though, that our realm of consideration is not limited only to these 4 options. In fact, it hasn't been consolidated at all at this point. all items still remain very much on the table for discussion. This is more or less a place to start.
But I guess until you make those decisions, the RFP is still a ways off. Is that inaccurate?
Yes, ma'am. That's
Okay.
correct.
So we're all acknowledging that the timeline is optimistic,
Yes, ma'am.
but you don't have any other kind of dates that you're...
We are currently reassessing
Okay.
how our timeline needs to be adjusted, and we look to have that soon.
Thank you.
Like, let me ask you, you touched on this, but let me get you to expand on it just a little bit about the copay. And one of the options, I think, had a mandatory copay, you said. And what has kind of concerned me sometime in the past, what we've done, we have increased the copay to try to help control the cost. And what happens when a patient goes to a provider, if they can't pay the copay, they're still receiving the service. So in effect, what has happened is the provider, that copay payment really is coming out of the provider's hide, because if the patient doesn't pay it, they're still getting the service, and then they're reimbursed at a rate as if they had received the copayment. And you mentioned, I think it was California that asked for a waiver to require that, but it was turned down. Talk about a little bit about that.
Yes, sir, that's correct. California applied for a Section 1115 waiver with Centers for Medicare and Medicaid Services, which was declined. Of course, the whole premise behind copays is to steer patients into receiving care in the most appropriate setting. However, we do know that the rules around the federal rules around the Medicaid program do not allow us to enforce those copays, and we do acknowledge the effect that oftentimes that means on providers.
Let me ask you one other thing. We had had a group that came down and spoke with us several months back and talked to us about the North Carolina model and what they had done up there. Was that taken into account, or did the Navigant, when they were doing their work, did they look at that model, or did you hear anything specific about that? We had a much more involved provider involvement in this thing.
Yes, Mr. Chairman. There has been extensive analysis of the North Carolina model, and in fact, it's ongoing. Both the Navigant team has done an assessment of their program, as well as Dr. Dubberly, and chief of our Medicaid division, has been in contact with the head of their Medicaid division, and we continue to have conversations with their program. A couple of items that we've been able to identify to this point. The CCNC, or Community Cares North Carolina program, that is often referred to and is very popular in the state of Georgia, runs approximately $2,000 per member per year more than Georgia's Medicaid program. So it is a costlier program. In terms of the administration of the program, it's very administratively heavy. In fact, in North Carolina's Medicaid division, they have more staff personnel than we have in the entire department, which includes our largest department of health facility regulation, which is generally, inspectors on the ground, approximately 300 to 350 of those alone. So it is very administratively heavy and would be a challenge, I think, for the department at its current staffing level to be able to administer a program of that nature.
Okay. You have another question, Representative Garner?
Lots more questions. The focus group that I was in talked a lot about the North Carolina model, and not very much reflected in this report. So I think one of the questions I have is, and I haven't read it all, but I have looked through various sections, is to what extent were those focus groups important to you in the decision making?
Extremely, and we certainly we have all the documentation and such that was produced in those focus groups, and they are being utilized as we continue our assessment. I want to assure you of that. The North Carolina model is generally reflected in the enhanced primary care case management discussion within the report, because that's generally what that program is. So that's sort of the basis, but I can tell you that there has been extensive additional research that's been done within the North Carolina model, and that continues.
So it is part of your consideration.
Absolutely.
I mean, the question that people are asking me about is the extent of the carve-ins. I mean, how do you plan to move forward with the various populations? We know, perhaps with the expansion of Medicaid, that some of the categories that we've created may go away, but we have a lot of different categories, and there are lots of different services with different
That's right.
ways to get paid, and providers may treat them all but get paid and have different rules, and it's pretty chaotic. But I know there is talk about carving in, carving out, and I wondered how those decisions are moving forward and kind of where you are with what you think you might carve out, what makes sense, and kind of how you envision implementing that over your time frame.
Sure. Again, all options still remain on the table, and we haven't made any decisions either globally or within particular populations or services how the department intends to proceed. But I can tell you that during the analysis phase, which we're currently in, we're looking at every service and every population individually to determine what is most appropriate. And in terms of implementation, we do anticipate a very robust, phased-in type of approach. So it wouldn't be a January 1, 2014, flip the switch, everybody's in. We're looking at a phased, structured approach in terms of any type of changes.
Which part is robust, the phasing or the go live?
The phasing.
Okay.
The phasing. Yes.
So you don't, if you're going to include them all in a kind of an all-in system, you don't imagine that you will do that all at once. You would do one population at a time, if that were the goal?
Well, yes. The goal is to do it in a very organized, phased approach so that we can minimize any type of impact to a member. And that will depend on a lot of analysis, I think, to determine, what that looks like, what that phased structure looks like. But it definitely, that's definitely the course we're attempting to take.
Want me to keep going? I'd love to give. I've got 15 more questions. Sorry, y'all. Don't you have any questions? Just keep going. Oh, you're liking my questions. Well, one of the things I noticed in the report in Chapter 3 on the National Environmental Scan is when all the states are the costs. I mean, we want to make sure we can afford to pay for this program, and I have to sidetrack to say that when we talk about how much this is going to cost the state, we need to be reminded of the $23 billion that's going to come to our hospitals and doctors to treat the patients that we know need health care. So it's, 100% for a certain number of years sounds attractive in some respects. But if I look at this, Georgia's expenditures per person are lower than any of the other states, southern states, and even some other states around the country. So we probably all believe that some reform is necessary, but are we going to end up spending more per person?
One of the key goals of this redesign is to maintain financial operational stability and to have a program that achieves long-term financial savings. This ties hand in hand with certain prevention programs, for instance, that may require an investment on the front end, but may be very likely to have a significant return on investment in the out years. No decisions have been made as to whether or not those types of investments will be made, but we do have as a central requirement of this redesign to develop a program that is financially stable and is one that achieves long-term savings.
I think one of the things that I've been concerned about with the implementation of the CMO several years ago was part of the strategy was to make sure that the quality of care, the quality assurance could somehow be determined. And it was such an overwhelming task that it seemed to me that DCH did not have adequate resources in the department to help us know whether we were getting what we were paying for. I mean, we're paying lower than any other state. That should be good, but are we getting the services that we need? And I'm concerned about the information, and I suspect that the managed care companies are providing you with tons of information, some of which may be useful, but unless you have somebody to analyze that data, I haven't been comfortable with understanding that maybe it's costing us a little bit more, but we're getting more for our dollar. And how do you see that as you look to make this change? It seems critical that we know whether or not, we all know there are folks who think they can come in, save us money, and do it more efficiently and keep the emergency rooms empty. But we haven't seen data to show that that's really occurring. So I'm really looking for the accountability that will show the quality of care that we're getting for the dollars that we're spending.
I think you hit on an excellent point and a priority of Commissioner Cook, which is making sure that we have appropriate contract oversight and we've got the appropriate resources within the department. And again, this gets at the concept of value-based purchasing, being certain that we're getting what we're paying for. So that is certainly a priority for this redesign. Georgia's come a long way, I must say, in the area of quality. We do track a number of HEDIS metrics, and in fact, just recently, Secretary Sebelius recognized Georgia for its efforts in tracking and driving improvements in quality. We also do have, as part of our contracts, quality improvement programs. One such program this year requires the managed care companies to reduce the incidence of preterm birth and low birth weight babies by at least 4%. So through those types of requirements that we are able to do as we re-up contracts, we are able to steer the program, identify areas where our cost drivers are, where quality is lacking, and be able to take strong steps forward in improving those areas.
I think I've seen some of the research that shows that they're making progress in that area, and that's terrific. I guess we need to see more areas where, and you may have that information, but I haven't seen it.
If I may, we also have heard quite a bit from providers about the desire to see more clinical or quality data. So that is part of this consideration as well. How can we empower providers who we are asking to manage this population and coordinate their care? How can we be sure that they have the appropriate information at their in their hands to be able to make the appropriate decisions?
Well, you did hit on one of the hot spots for me, and is how can you do quality assurance on children when you only are guaranteed to have them for 6 months, and then they have to renew, or maybe they drop out of the program. So that, the 12-month eligibility, I think, is probably, I don't even have to say it out loud. It's on my mind.
Right. We're certainly considering that as well.
I think it's
Representative Gardner has been a real advocate for the 12-month.
I think it's going to save money in the long run. It's one of those things that in the initiation may get a little bit of may cost a little bit more, but it seems well worth it, although I understand that's all going to change. So
we have some special guests who just came in with us today, and it's a group that's visiting.
Bobby, thank you.
How about introducing yourself and tell us who you have with you, please?
Thank you. My name is Bobby Paul, and I'm the Executive Director of Georgia Women's Action for New Directions, commonly known as WAN. And my representative is Pat Gardner, and thank you, Pat. She just offered a room to us on the 5th floor. And we have students from the Generation Latino in Cobb County and Campbell High School. So they've been here learning about the Capitol and about the importance of voting. And today, this is the action at CLOB, so that's why we're here. And I'm sorry for disrupting, but we're just going to stay for about 5 or 10 minutes, if that's all right with you all.
Sure. We're glad to have you. Welcome.
Thank you, Chairman.
If I can say bienvenidos a nuestro Capitolio. I didn't plan this.
Oh, yeah, right.
The old Spanish teacher comes out.
Well, let me ask you a question, and you may not be able to answer this, but when we decide to implement this program, or when you sit down and say, this is when we're going to begin the program and this is where we're going to go, and you look at what it's costing us now, and then when we changed and convert to a new plan, would you be able to come up with a figure that says, if we change from the way we're doing it now to this new plan, would you come up with a dollar figure that we should save or cost, or what? How will that work?
Yes, sir. We will have financial projections for any model that's proposed. Our actuaries are working on developing data books and conducting analysis as we speak to provide that financial impact analysis to us.
And when do you anticipate that you'll have this?
We are hoping in the middle part of April, so very shortly we'll have the data. And again, this will be essentially, we'll be able to break out certain populations, how they may be either transitioned in or maintained out of a certain program, as well as services, and be able to identify what the cost impact of incrementally, what those may be, and then also as a whole, what we can expect to generate in terms of expenditures and savings over the life of the program before that's moved.
Well, now, will that be based on one of these 4 options there that you have, the Georgia-specific options, or have y'all decided already on an option that you're going to proceed with, or what?
We have not identified any specific option, and we would anticipate the full analysis to be done on whatever option that is, with all the pieces combined, and they'll have to look at that individually. It may be reflective of one of these 4 options, it may not, but at this point we aren't at the level of granularity to be able to make that determination.
And so you're going to get that next month?
Well, the data book, which is the basis for being able to conduct the actuarial analysis, we'll have, and then as we continue to evaluate options, we'll be working hand in hand with the actuaries who will be doing both incremental and broader analysis for us, but we do anticipate to have that prior to moving on any plan.
Okay, so it'll look at, like each one of these has several different components or something. They'll give you a cost analysis on a component, and then when the plan is built, it'll take all these into consideration, and that's the way you'll come up with a number.
Yes, sir.
Is that right?
That's correct.
Okay. Let me ask you one more question. And I think you mentioned this about phasing this in, and I know in the past when they have converted from some provider service groups or administrators or whatever, there had been some real problems with that conversion. But what y'all are looking at, I think I understood you to say, is when you make your final decision, you're going to do it in such a way that it's going to be phased in and not just all or nothing at one time. Is that correct?
That's correct.
Okay. Representative Gardner, you have another question?
2 more questions that are real important to me, and that is that disease management makes sense to me. I mean, we have a few people who are spending most of the dollars. Thank you. And we have in the past had a program, Georgia Enhanced Care, and I know some of those programs didn't work the way we anticipated, and I think in our budget we saw that they were canceled mid-year. I still think treating asthma, diabetes, some of these chronic conditions is an important way for us to save money and make sure people are getting the care that they need. But it's a real people-intensive. It takes a lot of case management to call up and say, are you taking your whatever you're supposed to be taking? I mean, compliance is a tough thing because of behavior change, which is no easy deal. So how important is disease management, and are there some new ideas that Navigant maybe has identified for you that will help us manage those chronic diseases?
Sure, and I think you're exactly right on point. Case management, disease management is critical, and the extent to which a particular member may need, disease management or case management varies. And so we've got to look at the level to which those services are necessary and be able to design a program to address that. And it gets at sort of the difference between some of the concepts that really underlie a lot of the managed care options that we talk about, such as the patient-centered medical home, which provides that care coordination, and then moving into an enhanced primary care case management program that may wrap in more services, and perhaps services that only certain populations need more than others, like community supports or supported housing, things of that nature. So at the underlying issue and point to your question is case management is important. We are definitely looking at ways that we can maximize disease management and avoid those costs.
Just as a follow-up, Mr. Chairman, if I could, I mean, mental health treatment is real important to me, and we are living with a Department of Justice agreement. And if we look at people who are really good at managing diabetes, could be the pharmacist, or could be some kind of a case manager, but they're not necessarily the same people who would be very good at managing somebody with major depression. And I worry about the all-in process, that we're going to get the expertise in the specific illness that we need.
You've highlighted a key point, and one that's under a lot of thoughtful review at this point. The Navigant report speaks a lot to that, the importance of combining management of both physical and behavioral health and looking at the person holistically and as a whole. It's a challenge to identify the best environment for certain members to receive that management, but I can tell you it's under a lot of thoughtful review at this point.
Right. And it certainly will be part of your phase-in process.
Yes.
Yeah. Thank you.
Questions? Well, Blake, I think you've overwhelmed them or answered all their questions or whatever. I want to thank you and Jesse for coming today and in your presentation. Thank our members for being here, and we thank those of you in the audience who have an interest. And our students, we welcome you to come down and see how things work down here at the Capitol. We'll adjourn the meeting. Thank you.
Thank you, Mr. Chairman.